hello to everybody here and to folks at Beth Israel and at Kingston. Our speaker today is Dr. Robert Fletcher. He is the founder and the chief executive officer of the National Association of the Dually Diagnosed, so addressing the needs of patients who have intellectual and developmental disabilities comorbid with depression. Dr. Fletcher has worked for NADD as the founder and has really been its guiding spirit for the last 40 years. He's brought it to the position where it is now the world's leader in addressing the needs of this population. He's been involved as a clinician, as a program developer, a policymaker, researcher, consultant. He's authored numerous articles. He has edited or written 10 books addressing the mental health aspects of persons with IDD. Most recently, he has spearheaded the efforts of NADD in developing their accreditation and certification programs in an effort to really raise the bar in addressing the needs of this population. He also informs me that he is a skier and he's going to be skiing his last run tomorrow. So in anticipation of that, we'll have you come and share your wisdom with us. So it gives me great pleasure to welcome Dr. Robert Fletcher.
Thank you very much. Thank you. It's a pleasure being here. I'm from upstate New York, outside of Kingston. Actually, our corporate office is in Kingston, where the Catskill Mountains intersects with the Hudson River. People familiar with the Mid-Hudson Valley? Beautiful area. Highly recommend it. Go up there for a nice weekend. Get away out of New York. The talk we're going to have this morning is on integrated care, the interface between primary and behavioral health in persons who have an intellectual disability. I was really glad to hear that you already have an integrated care model in your family practice operations. And if there's time, we could have a conversation about that and have a dialogue on how that might be tweaked in order to be more responsive to the needs of individuals and their families. Unlike you guys, I am not an MD. My doctorate is in social work management, which I got here in New York City at Hunter College School of Social Work, City University of New York. Okay, here's today's outline. So there's a bunch of things we're going to talk about. We only have an hour. And what I'd like to do is kind of focus on areas that are of particular interest to you. So I'll be relying on you to give me some guidance on, you know, we want to focus on this, could you? So I would like it to be somewhat interactive, and I welcome questions, questions from the audience here, as well as questions from the off-site venues. So I guess those questions could be written out, and Becky will then submit the questions to me, and that's how we'll proceed. So I encourage the questions. What is NADD? We're 40, I've been in the field over 40 years. I founded NADD about 34 years ago. It's an organization, a non-for-profit, established to promote effective treatment, services, policy, research for individuals who have an intellectual developmental disability co-occurring with mental illness. This is our mission statement: to advance mental wellness. So everything that we do, you know, I'm going to talk a lot about psychiatric disorders and psychopathology. Our focus and our mission is always around promotion of mental wellness. We publish journals. We have a book publishing company. We do 24 webinars a year. We have an accreditation certification program. Out on the table, there's a brochure about our organization. So if you'd like more information, pick up one of these. Feel free to contact me. I'd be glad to answer any question you may have. What is integrated care? Integrated care is the result of a practice of coordination, collaboration, integration between primary health care and behavioral health care. And I understand you already have that model in your practice, and I'd like to talk about that as a Q&A part comes up. It's working together, not only between the primary care folk and the behavioral health care, but also within the context of the person being served and their family. And this becomes critically important in working with individuals who have an intellectual or developmental disability. Integrated care means we have a thought-out systemic approach for services that are person-centered, cost-effective, and result in increased quality of care, with ultimately increased quality of life for the individual that we're serving. In my travels across the country, we're starting to see the beginnings of integrated care. It's in various stages, in various places. I'm really pleased that your own family practice operation has the essential components of an integrated care. But it's really important. We need an integrated care model where there is collaboration between primary health, behavioral health, and dialogue with the family and the individual in order to produce effective results. And also, it culminates in significant reduction in total healthcare costs. In looking at an integrated care model, we need to have communication. The arrow reflects communication between primary care and behavioral health care. We can't have separate primary care, or shouldn't have. I mean, that's essentially, we live in silos. In most areas of the country, there's primary care on one side, and behavioral health care on the other, with very little interaction in between. In a really true integrated model, and that's why they use the word integration. I'm not so sure I'm very fond of that word, but that is the prevalent word that's used. It's more of a collaborative care model than an integrated care model. But what it does mean is that we need a dialogue, a conversation, communication between the various disciplines, behavioral health and physical health, in the context of working with the individual and their family. Why is it so important? It's the right thing to do. It ends up with good quality, improved care. It results in significant cost savings. It's our ethical responsibility to provide the best type of care and treatment to our client population. Overall, what research has demonstrated is that integrated care models not only saves a whole lot of money through health cost expenditures, a reduction of health cost expenditures, but also results in improved care and quality of life outcomes. Economic impact of integrated care model. This Milliman report was commissioned by the American Psychiatric Association recently, 2014, to really focus in depth on the relationship between behavioral health and physical health, with an emphasis on cost expenditures and cost savings. Effective integration of medical and behavioral health care could save $26 to $48 billion in general health care costs across the United States. It expands the quality of care, and through the integration, leverages the limited resources we already have. When patients' mental illnesses are effectively addressed, they're better able to participate fully in the management of their physical health care. And conversely, if the patient's physical health care is managed effectively, they're able to better manage their psychiatric illness. So it goes both ways. Here's some key findings from this Milliman report commissioned by the APA. Most of the projected reduced spending is associated with facility and emergency room care expenditures and hospital facilities. People who have persistent and serious mental illness, as well as those who don't have serious and persistent mental illness, but some other behavioral problems, maybe not to the extent to which people have this chronic mental illness, often go to the emergency room as the first point of intervention. Usually not very appropriate. People who have an intellectual disability co-occurring with a behavioral problem are often referred to the ER when they're, as a result of the lack of effective community-based crisis intervention programs in the community. Furthermore, they wind up in expensive ER visits and often and unnecessarily wind up on inpatient units. Often wind up on inpatient units because of a behavioral problem that may or may not be rooted in a psychiatric disorder, but could be rooted in a physical health condition that masks, looks like, acts like, manifests like a psychiatric disorder. And I'll be talking a little bit more about that and giving some examples. So what we need to do in a integrated healthcare model, what an integrated healthcare model is designed to do, is to have a good communication between primary care, physical health, and behavioral health care, and in doing so, reducing costly, unnecessary ER visits and inpatient hospitalizations. Major cost savings through an integrated care model. Only 14% of people with insurance are receiving treatment for mental health or substance abuse disorders, but they account for more than 30% of total health care spending. So people who have mental health problems are very costly to our health care overall costs. People who have a dual diagnosis, an intellectual disability co-occurring with a mental illness, is reported to be one of the most costly and underserved populations in the United States. This is kind of conclusions or some summary statements about the Milliman report with regard to the economic impact of integrated care. Mental illness should be treated in conjunction with other medical conditions, and the findings demonstrate the potential impact that integrated behavioral health models could have on healthcare spending for treating some of the most costly healthcare conditions. Let's talk about the intersection of behavioral health care, primary health care for individuals who have an intellectual disability. We have these three approaches. We have a behavioral health approach. We have a primary care model approach. And then we have these people who have an intellectual disability. What we need is some communication and dialogue between these three circles, and looking at the core and assessing, evaluating, implementing a communication system, the collaboration, the cooperation, or I call it integration, between primary physical health in the context of the individual that we're serving. General health, mental illness, and ID. Evidence suggests that mental illness or intellectual disability conditions are more medically compromised than those who do not have either one of these conditions. Evidence further suggests that people with mental illness or an intellectual disability have a shorter lifespan compared to those who do not have these disorders. And evidence suggests that costs of psychiatric care and cost of medical care are significantly greater than those who do not have these disorders. Any comments or questions on integrated care model? Let's talk about the notion of comorbidity of intellectual disability and mental illness. People with an intellectual disability can develop the same mental health disorders that the general population can experience. That includes all the major psychiatric disorders, as well as those other psychiatric disorders we don't hear that much about, but are listed in the DSM system of diagnostic nosology, including personality disorders. So the full range of psychiatric disorders that are represented in the neurotypical population are also represented in persons who have an intellectual disability. In fact, the prevalence of psychiatric disorders in persons with intellectual disabilities is 3 or 4 times greater than those of the general population. About 2% of the general population have an intellectual disability, and of that 2%, approximately 40% would show signs and symptoms that would warrant a psychiatric diagnosis. 40%. Cumulatively, it's close to 2 million people across the country have comorbidity of a psychiatric disorder and intellectual disability. It's difficult, however, to assess and diagnose psychiatric disorders in persons who have an intellectual disability because of the deficits in expressive and receptive language skills. So if you're interviewing, interviewing an individual with a neurotypical population, and you're doing a mental status examination and asking questions, you would expect that individual to give you verbal responses that would help you formulate a diagnostic hypothesis at the end of the interview. That may not be enough. That will not be enough for persons who have an intellectual disability. The interview alone is rarely diagnostic in and of itself. It's a condition of, but insufficient for, a full developmental biopsychosocial assessment. Even the DSM system, how many people here use the DSM? One? Everybody knows what it is, right? But the DSM system is based on the patient giving a self-report. So I go to the doc, I say, Doc Becky, I don't feel good, I don't want to get out of bed in the morning, I feel tired all the time. By the way, I lost 10 pounds in the last 2 months. I just feel like crap. I have to go to work. I come back from work. I throw the covers over my head. I stay there until I have to get up the next morning. I don't want to go to work, Dr. Becky, but I have to go to work because I got to pay the rent. What's the diagnosis? Depression. What about if I didn't have those verbal skills? You came up with that in about 30 seconds. So it's very difficult to come up with a diagnostic impression, no matter how much time you have, if you're only interviewing the individual. So it needs a lot of contacts with collaterals, and I'm not going to talk about it today because there's not enough time, but there's a book that NADD published called The Diagnostic Manual for Individuals with Intellectual Disabilities. I was honored to be the chief editor of that. We're now working on the next version. It's a companion to the DSM-4 TR. In fact, the first diagnostic manual we did was done in collaboration with the American Psychiatric Association. And it uses the same categories as the DSM system. All the diagnostic nosology categories are listed, but how you arrive at the diagnosis is much different. It is not based on patient report, but based on observations and other collateral input. But our research indicates that it has great clinical utility, and the research also suggests that it is more clinically viable than using the DSM system, because again, that relies on self-report. So CARES are able to assist in the assessment process by providing information about the person. When we do a mental health assessment with an individual who has an intellectual disability, we need to really bring to bear an array of collateral information. If the individual is living with mom and dad or natural family, it's critically important that mom and dad be brought in to the interview session to help to get background information, developmental history, school history, family dynamic information, and so forth. What we do in the field of dual diagnosis is when we do an assessment, it's done as an interdisciplinary kind of approach. Because the person doing the assessment, whether it be a primary care provider or a psychiatrist or other behavioral care clinician, it's important that we do it in the context of obtaining information and conducting it along with other disciplines and getting input from other collaterals. For example, and child psychiatry are well trained in this, but adult psychiatrists are not well trained in this. If a child psychiatrist, we could borrow a lot from child psychiatry when we're working with adults who have ID, because there's a lot of parallels, a lot of similarities. A child psychiatrist, when conducting an interview with a child, would typically get information from the child's teacher and the child's mom and dad. We would do the same in principle with an adult who has an intellectual disability. Rarely does a child psychiatrist only see a 7-year-old in the absence of mom and dad and other collaterals. They wouldn't do that. They're not trained to do that. Either are we in the field of dual diagnosis. It's an interdisciplinary or multidisciplinary approach. And we need to be aware that the mental health evaluation can be very distressing for the individual and very distressing for the people who care for the individual, who bring the individual into the interview session. We know, and there's a substantial research to indicate, that people who have a dual diagnosis are at greater risk for obtaining physical health comorbidities than the general population. Let's look for a moment at the interaction between physical health, behavioral health, and ID. Biological influences. A person's genotype can determine not only his or her physical characteristics, but also behavioral characteristics, behavioral phenotype. An example, individuals with ID and Fragile X syndrome are predisposed to develop attention deficit hyperactivity disorder and complex partial epilepsy. Another example is individuals with ID and Prader-Willi syndrome are predisposed to develop self-injurious behaviors and psychotic disorders. Let's look at this interaction from a psychosocial influences. Psychosocial and social factors can influence the expression of biological predispositions and vice versa. Example, the development of Alzheimer's disease will have significant psychosocial consequences in people with Down syndrome. Complex biopsychosocial interactions. People with ID present with more complex interaction between biopsychosocial factors and their physical and mental health. Here's an example. Sexual abuse is more common in people with ID. In reading the research, I've known the research for decades, but every time I think about it, it's mind-blowing. The majority of people with ID have been sexually abused. Isn't that an outstanding statistic? About 70% of people who have an intellectual or developmental disability have been sexually abused. So the chances are, if you look at your own patient load and think of the people that you have on your patient load who have ID, chances are they've been sexually abused. Have we ever considered the soliloquy of that? Have we ever considered the emotional impact as a consequence of that abuse? We don't. We rarely do, and we need to pay attention to that. It's not easy, though. It's very difficult to diagnose somebody who has limited verbal skills and accurately come up with a diagnosis, if it does exist, of, for example, post-traumatic stress disorder. But there are ways to do it, and NADD has a wealth of information on how to conduct those type of assessments. Talk a little bit about medical problems and problem behavior. Again, the interface between physical health and mental health in persons who have an intellectual disability. It's quite a clinical challenge when looking at symptoms and signs of persons who have an intellectual disability and when they're exhibiting a behavioral problem to really ascertain what is going on. Could it be a symptom of a psychiatric disorder? Could it be he's behaving in a certain way because he learned that from his older brother, learned behavior? Or could it be a medical condition? We're looking at behavior and the manifestation, but what is driving that behavior? And in many instances, it is rooted in a medical issue that is manifested in a behavioral way. Follow me? We know that medical conditions often go underdiagnosed in individuals who have an intellectual disability. Medical conditions can mask, can look like behavioral problems. And this happens a lot in individuals who have limited verbal skills. So rather than because of their inability to articulate a distress, a pain that they're experiencing, such as a toothache, they act out behaviorally in response to the distress that they're experiencing. So we don't know if it's a behavioral problem on the surface, if it's rooted in a medical condition, if it's learned behavior, or if it's a psychiatric condition. That's why we have to be like Sherlock Holmes. We have to dig. We have to be an investigator. We have to look very, very hard at all the possible causes of the problem behavior. These are some common medical problems found in individuals who have ID that can look like a behavioral problem. Something as simple as constipation, which is so common in this population as a result of a side effect profile of psychotropic medications, if the person cannot verbally express their feeling of feeling bloated and stomachache, etc., how do we know they have constipation? It takes some kind of Sherlock Holmes work. Medical problems and dental problems are often recognized. Medical and dental problems can cause self-injurious behavior. And we need to identify if there is any physical problem. When I'm seeing a patient and conducting a mental health assessment, I require, before I see the individual, a host of information. The first thing I want to see is a recent medical workup. And if the person has not had a recent medical workup, I refer them out for that before, as a mental health person, I see the individual. Case example. I took out of a dentist wrote this up in 2013, so this was actually a real case. 28-year-old female with ID referred to the dental office for routine dental exam. Prior to the exam, mother noted that her daughter, 28-year-old female, began pulling out her hair. The dental exam indicated a dental problem, specifically a fractured upper molar, and the tooth was extracted. Immediately, mother reported that the daughter stopped pulling out her hair. So the pulling out the hair was the behavioral manifestation, which was rooted in a dental problem. Once that dental problem was identified and appropriately treated, the behavioral problem no longer existed. Here's another example of medical problems and problem behaviors. It is not uncommon to see the manifestation of a mental health problem, how it's seen, observed, be very similar to the manifestation of a physical health problem. I gave two examples. One is on mania. Could look like akathisia. So is it a psychiatric problem or a medical problem? Another example is depression, and the manifestation of depression can look like constipation. The end behavior pattern can be very similar. So we need to be like Sherlock Holmes. Any questions so far? Yes?
In that example you just gave, if you have parallel symptoms for physical and mental health, how do you treat that? What do you do with that?
Well, first you have the individual go through a full medical workup. Always checking out medical problems first before you go on to the behavioral health problem. If you have persons who have an intellectual disability and having some challenge in expressive and receptive language skills. If the person has very good language skills, if the person has good language skills, then you might want to proceed as you would with the neurotypical population. But if there's any difficulty with language skills, always start off with medical. And I think that's a good practice for everybody. First checking out medical possibility of having an ideological root before we look at any other psychiatric possible related issue. Any other questions? Okay. I'm going to leave some time for some questions, and I was talking to some people actually before the lecture started, and it was suggested I talk a little bit about psychiatric mental health assessment practices. So anything like that, I'd be glad to, we could have that kind of conversation. So I'm going to leave some time for that. Guidelines for psychotropic medications for persons with ID. I decided I'm not a medical doctor. My doctorate is in social work management. So why is this guy talking about medication to docs when he's not a doc himself? I'm not going to be talking about specific prescribing practices or dosages, but more overarching principles of prescribing psychotropic medications for individuals who have an intellectual developmental disability. We know, and research certainly gives us the evidence, that medication treatment is the first line of treatment for individuals who have an intellectual disability. Not saying that that's appropriate, that's just a fact. 1/3 to 1/2 of adults with ID are taking psychotropic medications, with or without a comorbid psychiatric disorder. So, if we have 1/3 to 1/2 of adults taking psychotropic medications, why? What's the reason? Let's look at the gaps in research and practice. Certainly, what we know in terms of psychotropic medications and prescribing practices far exceeds what we do. What we know far exceeds what we do. Practitioners do not make medication decisions necessarily based on empirical evidence. That's what the research is telling us. That's not Rob Fletcher telling the docs. I'm citing the research. Psychotropic medications are regularly dispensed for mental health conditions for which there may be no evidence for their effectiveness. By the way, most of the good research comes out of Europe because they have funds to do research in people with intellectual disability. In this country, our research funds fall through the bureaucratic cracks in Washington. You know, there's the Bureau, there's National Institute for Mental Health and National Institute for Child and Human Development for people with developmental disabilities. What about people who have a dual diagnosis? So there's no funding source. So the good stuff comes out of, the good research comes out of Europe most of the time. Research suggests that psychotropic medications are commonly used to treat aggression in individuals with ID, despite the lack of evidence for these medications that lead to the reduction of aggression. Now, most referrals made to behavioral health clinicians by the referring agency or person for a person who has an intellectual disability is usually because some act of aggression. Hitting, spitting, biting, kicking, pulling. Some act of aggression. That, and in the absence of knowing how to do a good developmental biopsychosocial assessment, that treatment for the aggression is often, first line of treatment is medication, a psychotropic, a neuroleptic medication, and that is used often to mask the behavioral problem, not to treat any underlying psychopathology. And we got to get beyond that. There was a book I was quite impressed with called Psychiatric Medications and Developmental Disabilities, an International Consensus Handbook, which came out, it's not recent, but it's still probably the best guidelines that we have in our field. And it was written by Dr. Reese and Dr. Amen from Ohio State University. And the consensus guideline came out of a conference, which I happened to be at, where experts from around the world came together for a week to discuss and develop a consensus guidelines. And the work that I'm going to be citing now is based out of this book. So I want to talk about 8 guidelines for the use of psychotropic medications for individuals who have an intellectual disability. Guideline 1, psychotropic medications shall not be used excessively as a punishment, for staff convenience, as a substitute for services, or in quantities that interfere with the individual's quality of life. What often happens is that an individual will be referred to a primary care physician or to a psychiatrist by the group home provider or by mom and dad if they're living with their natural family, and saying, "Doc, give him some medication. He is out of control." So the doc complies. Psychotropic medications are applied with or without identifying any underlying psychiatric disorder. So that psychotropic medication then is used to mask. It's used to as a behavioral control rather than for any treatment purpose. That we have to get beyond. And I know physicians are influenced and are unduly, actually, by the care provider and family. I know that docs are really at, please, please, please give him something, he's out of control. So yeah, I mean, we can mask the problem with enough medication. Anybody can be sedated. But we should not use medication only because staff wants it, mom and dad are asking for it. It can't be used because the staff aren't adequately trained, that the environmental conditions are inadequate for inappropriate for that individual. We can't use psychotropic medications for untreated medical comorbidities. And we can't use medication as a substitute for appropriate behavioral interventions.
I have a question about that.
Yeah.
You said you can't use the medication for behavioral control.
We should not use medication for the specific purpose of controlling behavior. Now, that behavior may be controlled because we're targeting the psychotropic medication based on and associated with a psychiatric disorder.
You know, I think that's a matter of semantics. You know, I have a nephew who's intellectually disabled. He's 29 years old now, and he can function fairly normally, you know, with the family. He can go out to dinner with people. He can interact with people. He has no verbal ability at all, but that's because he's on medication. When his medication is stopped, he is not only horrible to deal with, but he's distressed all the time. And so that distress, you know, the distress is lessened by the use of medication, and he can function in a family, and he smiles and he's happy. But when he's in distress, he's neither happy himself, nor is anybody around him happy, and he can't be out in public. So, and it's strictly used to control his behavior. Nobody can understand what the psychiatric diagnosis is behind this. You can't like make a psychiatric diagnosis, and it's been completely trial and error over the years to use medications in the hands of very skilled, you know, psychiatrists and behaviorists. It's really been sort of, you know, a trial and error kind of process. But now he's in great shape. So, but if you were to say, why is he on this medication? It's to control his behavior. Because when his behavior is controlled, he can function in society, and he can live in and be happy around his peers and his family, and go to school. And so those are all good things.
That's a wonderful situation for him. No, it's a wonderful situation for him.
But nothing.
However,
How do you make a psychiatric diagnosis?
we can talk about that. Let me finish the guidelines, we'll talk about that. Could it be possible, I'm glad to hear that story. That's a lovely story, it really is. I can relate, I'm a family member, so I can relate to family situations. Could it be possible that your relative is being treated, is under control with his medication, and has some kind of psychiatric disorder? That medication is mediating, is hitting, is targeting, is working. It's possible. The other thing I wanted to mention here on this guideline is that we should do assessments based on a multidisciplinary team approach, getting feedback from care providers and collaterals, and not only with the one clinician. The research indicates that significant reduction in medication usage when a multidisciplinary team is involved in the decisions as to whether such medications should be used. Guideline number 3. The use of psychotropic medication must be based on a psychiatric diagnosis or specific behavioral pharmacological hypotheses resulting from a diagnostic and functional assessment. And this may relate to your question. This guide means that psychotropic medication should be prescribed for specific psychiatric diagnosis, or in response to a documented connection between the cause of unwanted behavior and the medication's known propensity to act on that cause. So let me take that piece and see if it applies to your family and the individual member of your family that you're referring to. Psychotropic medication should not be prescribed simply for behaviors or aggression without a proven cause and effect relationship. So I'll retract in saying, we should never use psychotropic medications in the absence of a psychiatric disorder unless there is a response that's documented that shows a connection between the cause of unwanted behavior and the medication's known propensity to act on that cause, which I think is the issue that you were referring to. But by and large, as a principle, we shouldn't be just giving out medications to control behaviors in the absence of looking at these guidelines. 4, a written informed consent, asking those kind of questions, or seeing if the individual has a guardian. 8, specific index behaviors and quality of life outcomes must be objectively defined, quantified, and tracked using recognized empirical measurement models in order to monitor psychotropic medication efficacy. So we're using a certain medication for how long? What type of indices or measurements to see, is it working? Are we monitoring how it's working over what period of time? And are we documenting our findings? The individual must be monitored for side effects on a regular and systematic basis using accepted methodology, which includes standardized assessment instruments. So we really should pay close attention to the medication and side effect profiles, which could have in some situations, a devastating effect on the individual. Sometimes, as you know, the side effects of the medications can be worse than what you originally got into in treating the individual to begin with. This is more on monitoring side effects and assessing on a regular basis if there's any tardive dyskinesia and so forth. Psychotropic medications must be reviewed on a regular and systematic basis. It is recommended about once every 3 months, checking on the individual, their medication, the efficacy, the side effects, and get input from the collaterals for mom and dad, group home providers, to ask questions about compliance and if you're seeing the same kind of effects of the medication that the care providers and the client is reporting to you. It's kind of just a summary, some other best practices, identifying changes that are expected as a result of taking the medication, and that should be communicated to the family. Identify what type of time frames would occur in checking the medication and the side effects of the medication, if it's working, not working. And I think we need to, this is all about collecting data, maintaining data, and sharing the data with the relevant care providers and other stakeholders involved in the care of the individual. The diagnostic impression, when I do a diagnostic workup, I'll come up with a diagnostic hypothesis. And because it's a combination between an art and a science, sometimes more of an art than a science, but so I can never come up with a definitive psychiatric diagnosis. I come up with a hypothesis and check things out, monitor the individual, and then later on confirm, and then always on a regular basis, at least a couple times a year, reevaluating not only the medication, which should be reevaluated on like every 3 months, but reevaluating the diagnosis as well. What happens often, because of the complexity of this population, is that a diagnosis is applied, a medication regime follows, but it may not be the accurate diagnosis to begin with. And diagnoses generally stay with the person. We generally don't reevaluate and change diagnoses. And so I see, I go to facilities around the country and I see patients on medications based on a diagnosis they were given 20 years ago, which was inaccurate to begin with. Yet those medication regimes continued because of the initial diagnosis. So this is just kind of a model of how we do a diagnosis. We come up with an assessment, formulating hypotheses, beginning our treatment, whether it be psychopharmacology, maybe psychopharmacology combined with social skill training, combined with group or individual psychotherapy. Usually I recommend not just medication treatment, but a more holistic approach to care and treatment for individuals who have an intellectual disability. Continually monitoring the diagnosis, monitoring the medication, and the feedback loop, getting information and continual dialogue with care providers, and a continual evaluation of the effects and adverse events. And does our treatment, overall treatment, including not just the medication, but skill training, habilitation, psychotherapy, are we leading to an improved quality of life for the individual and their family? So bringing it back to the integrated model, I think if we can integrate, and in the setting that you are already in, as I understand it, you already have the essential components of an integrated care model. What I would suggest that you explore is some kind of arrangement whereby there is more actual face-to-face dialogue between the primary care clinicians and the physical health and the behavioral health clinicians. So you can actually have a discussion along with the individual affected and their family. So it's primary care, physical health care, patient and their family. And those three prongs being the basis of that dialogue, conversation around collaboration, cooperation, and integration. I'm going to leave a little time for Q&A.
Okay, hi. I'm a social worker. I'm going to say that outright. But I had, yeah, I know. So, but yes, there we go. Yeah, well, I worked with a young person who maybe I've been thinking about her during this. She was 16. She had Down syndrome. She was overweight, like obese. She had asthma, frequent utilization of the ER, and her mother had bipolar disorder. And the 16-year-old had gotten a diagnosis a long time ago of multiple personality disorder, dissociative identity disorder, and mom really latched onto that. And she had aggression in school, and her providers were in different places. So her pediatrician who treated the asthma was in one hospital, and then psychotropic medication from a psychiatrist in a different place, and then kind of social work interventions from another place. And so suggestions on, because I think that this is kind of what you're discussing. The daughter had limited vocabulary, kind of preschool level, and so relying on a mother who also had her own mental health needs. And where, what is the best, in your experience, point of contact of how to collaborate to get different providers who might not be like we have here, all integrated together?
Okay, yeah, thank you. Good question. So you're talking about an individual whose service is quite fragmented in different kind of silos. So what we need to do is, from a practical perspective, we are not going to bring those silos together around the table, right? But the communication could be done, even though we can't physically bring the psychiatrist, the primary care, the mother, the daughter all together, as you could in your family care model because you are in one building. But in what the example you're giving is a little different than the family care model you have here, is the role of the case manager or social worker could be the conduit of communication, so that a 3, maybe 4-page document be developed by the case manager or social worker who pulls together the salient features and components of the different fragmented services the individual's receiving, bring it together, and sharing that single document amongst all the stakeholders involved.
Do you have suggestions specifically for physicians who might be seeing this? Maybe a patient is coming here and this is their first or second time and they're presenting with some of these issues maybe the physician doesn't know that there's, sometimes there are other, like if a parent is struggling with their own mental health needs, they're maybe not the best historian to be coming in. So if a patient presents here and they have poorly controlled asthma and it comes to the ER for the last, once a month for the last 3 months.
Right. I mean, ideally, with that 3 or 4 page document that gives some background information and current information about this 16-year-old individual should be shared. Now, when that person goes to the ER, can that document go with the individual? That would be the ideal, if that could be worked out, if that's a practical matter or not, I'm not sure. But the principle being is that the information needs to be shared. That individual goes to the ER, and the ER personnel do not have a clue of what's going on from a background perspective on this individual. So that individual shouldn't go in just by themselves or just with mom for the reason that you stated, but maybe the case manager, the social worker, somebody who's involved with that individual and their family could accompany that individual to the ER. What's needed is what it's called a planned crisis prevention kind of method. If the ER already had information on that client, I don't know if that's done in New York City or not, but a kind of a planned crisis prevention crisis prevention plan that everybody knows about, that everybody can share. I don't know, with a computerized record keeping, that might be able to be done. I don't have the answer to the question other than the principle of sharing the information in any way that you think might, from a practical perspective, work with this individual. About the multiple personality disorder and the mother being bipolar and bipolar already having a genetic predisposition, I would highly recommend a re-evaluation for behavioral health people. It's not that an individual with ID can't have multiple personality. I'm not sure I have ever seen it in the research literature.
My name is Joe Laurie. I'm a family physician. I just want to make a comment and try and contrast the idea between sharing information, which of course is very important, having access to information, and communication. One of the problems with electronic health records, and we've had one at the Institute for, I guess 13 years, going on 14, and you get overwhelmed with too much information. And having access to information is different than communication. I once had a patient of mine say, "Don't you doctors talk to each other?" And the answer is, of course, no. But actually talking to each other is communication. So if I have access to everyone's medical record, then that's overwhelming. I don't have time to go through all of that stuff. But however, if someone says, "Doc, I've got this patient here. I'd like you to see if there's any medical problem which might be causing them to start to act out aggressively." Yeah. Then I can say, okay, now I know what I have to do. If someone comes into the ER, or comes back from the ER, that's a different thing. If I have a patient come into my office from a mental health facility or a shared care facility, and with just a physical form, and I say, well, am I doing an annual physical because they've got to click off one more thing on their checklist, or is there a specific task that I have to do or a question I have to answer? So one of the things that we have to do now that we're starting to communicate electronically or share electronic records is to find a way to actually communicate so that we can work as a team. It's not just having access to records, because there's so much that's daunting in of itself.
Yeah, thank you for sharing that. Absolutely. I think that the electronic record is a step in the right direction for kind of sharing, but it is overwhelming. That's why I was suggesting a 3 or 4 page biopsychosocial update it would be valuable in your situation as well as for other situations. And I can't agree with you more. The electronic record is a way to share information, but not necessarily to communicate with other physicians and people involved in the care and treatment of the individual. In the setting that you're in, as the way I understand it, and I don't have a real firm understanding, but in your primary care is all in the same building but a different floor than your behavioral health care. And through the electronic record, there's sharing of information. Do I have that part right? And what you're suggesting, I can't agree more, and we spoke about it before the lecture, is what I'm going to recommend is what you just said. So we'll take it from your recommendation. We need to develop a mechanism of actual having a conversation between the various stakeholders involved in the care and treatment. So having the electronic record is helpful, but like I said, it's overwhelming, and you're not having a dialogue with the psychiatrist. You're just reading what the psychiatrist had written, if you have time to read all that. And I appreciate that. I think having a face-to-face dialogue with other care providers concerning patients who are very complex makes eminent sense to me. And I can't share more what your point. I think very, very important.
That is indeed the first thing you said, is to make sure that there are dialogues happening. So we're sort of ending where we started, right? So thank you very much.
Thank you.